Welcome to the Kentucky EMS Personnel Injury and Exposure Pilot Study Project Educational Update. Today is December 19th, 2018. We're in beautiful Lexington, Kentucky. And in the room today, we have Dr. Matthew Groenwald, an epidemiologist from the U.S. Public Health Service and CDC, Monica Robertson, the data analyst here at the Board of Emergency Medical Services, and the voice you're hearing now is Drew Chandler, and I serve in the role as the data administrator. The objective of today's presentation is to educate EMS practitioners and service administrators in Kentucky about a pilot project our office, the Kentucky Board of Emergency Medical Services, is participating in with the National Institute for Occupational Safety and Health. As part of today's program, we're accepting questions by email to kstars@kctcs.edu, and we'll address those in a timely manner. This presentation is recorded for later publication, and that email box is monitored continuously, even though this is a recorded video. With that, I will turn this over to Dr. Groenwald for some background about the project.
Thanks, Drew. This is Matthew Groenwald. Hello and welcome, everybody. And I'd just like to say a few words about the background and ultimately about the objectives of the collaborative project that NIOSH has with KBEMS here in Kentucky. So working in EMS is dangerous. There's a little over 800,000 EMTs and paramedics working in EMS in the United States. And they operate in a work environment that exists at the intersection of the healthcare, public safety, and transportation industry sectors. And they're exposed to many of the occupational hazards with each of those. So EMS personnel are exposed to all the same hazards as other facility-based healthcare workers, such as exposure to infectious disease, sharps injuries, musculoskeletal injuries resulting from lifting and moving patients, and injuries due to workplace violence. They're also exposed to additional hazards specific to the largely uncontrolled pre-hospital environment in which they work, including exposure to hazardous materials, rescue operations, and treating patients in moving ground and air vehicles during emergency transport. This slide is an overview of some of the evidence that exists in the recent epidemiological literature for occupational health hazards among folks that work in EMS. And I won't elaborate each one of these studies, but suffice to say that compared to U.S. working population as a whole, people that work in emergency medical services are at higher risk for both injury and death, as well as hazardous exposures, than the working population as a whole. So we know that EMS workers are at increased risk, and that is what this project is ultimately intended to. In order to understand the problem of occupational injuries and exposures among EMS workers, you have to study it, and that means you have to measure it. In public health, one of the fundamental activities that we do when we're trying to understand the health of a particular population group is we conduct surveillance. And this slide describes some of the data sources that have been relied upon for conducting occupational health surveillance among EMS personnel. These data sources include the employer report-based survey of occupational injury and illness, the Hospital Emergency Department NICE Work System, which stands for National Electronic Injury Surveillance System. And those both have issues of sample design and sample size that limit their usefulness as systems for ongoing surveillance, specifically of EMS work. Neither of those samples of employers in the case of survey of occupational injury and illness, or emergency departments in the case of NICE work, is designed to be representative of injuries and illnesses suffered by EMS workers specifically. So as a result, annual EMS subsamples are small, and especially in the case of the SOI, are potentially biased, making them unsuitable for production of reliable annual or more frequent surveillance statistics. Additionally, problems identifying the appropriate external denominator make calculation of EMS worker injury and illness rates using NICE work problematic as well. So what this demonstrates is that there really is a need for new and better sources of public health data that we can use to understand, to more fully understand the amount of risk of injury, illness, and exposure that EMS workers experience while on the job. So, and another potential source for national surveillance data, the National EMS Information System, or NIMFIS, is what we're focusing on here. The NIMFIS represents an appealing source for national surveillance data as it can capture in near real time information on the occurrence of occupational injuries and infectious or toxic exposures among EMS workers from all or nearly all EMS responses occurring in each of the 46 participating states and 3 overseas territories, and does contain data that can be used to identify contributing risk factors. However, data on the specific type of injury exposure is not collected at the national data set level, and we'll have more to say about this later. It has to be obtained from the states, and that is why NIOSH has partnered with the Kentucky Bureau of EMS to accomplish this project. A subset of NEMSIS variables are routinely transmitted by state EMS agencies, including Kentucky, to the national EMS database maintained by the NEMSIS Technical Assistance Center in Salt Lake City. Not all of the variables related to injuries and exposures to EMS personnel are included in the NEMSIS national data set. So the use of NEMSIS data as a source for occupational health surveillance really has to involve partnering with state EMS authorities, which is what NIOSH has done with KBEMS. Currently, the vast majority of U.S. states and even some overseas territories routinely collect data on the geographic, demographic, clinical, responder, and operational characteristics of all or nearly all responses made by transporting EMS units, according to NEMSIS standards that are promulgated by the National Highway Traffic Safety Administration, or NHTSA. A number of data elements in the most current version of the NEMSIS standards, version 3, are designed to capture information relevant to the safety and health of EMS personnel, including the occurrence and nature of any fatalities, injuries, or exposures to the responding crew member, and their use of personal protective equipment. And this provides an opportunity for occupational health surveillance, which is what we're after. However, as I've mentioned a couple times before, states don't send this data to be included in the NEMSIS national data set, and that's why we're working with our state partners, including Kentucky. But the use of EMS response data as a source for occupational health surveillance is an opportunity that's appealing because it takes advantage of pre-existing data that was designed to be collected and used to document occupational safety and health of EMS personnel, but until now really hasn't been utilized for that purpose. And although it is possible in principle to do so, until now there's really been no national effort to aggregate NEMSIS data from multiple states for occupational health surveillance of EMS personnel. And that's really the objective of this project. What I'm going to do now, having spoken a little bit about the background of this project in general, I'll turn it back over to Drew to talk about some Kentucky-specific information.
The first actionable activity related to EMS data in Kentucky is in May of 2009. Between that time and August 2012, there were several false starts to a consolidated data collection effort. In August 2012, a full-time employee was added at the Board of EMS, and that individual was tasked with leading the charge and was instrumental in setting the direction for what we know today as the Kentucky State Ambulance Reporting System, or KSTARS. KSTARS is the state NEMSIS repository of information collected by the individual EMS crews involved with patient care, and that is rolled up on a call-by-call basis into this repository. Data submission became a required activity with the passage of Chapter 202, Kentucky Administrative Regulation 7540 in August of 2013, using the latest version of the NEMSIS standard. The regulation includes language about timeliness, which we'll talk a little bit more about later, that being currently the 15th of the following month. and a minimum continuity of care information data set to be left at the hospital prior to the crew's departure. In June 2014, Kentucky began its transition to NIMSIS version 3 by publishing a timeline with key milestones for ambulance services to make the move from an older version of NIMSIS, or in many cases, begin the use of electronic pre-hospital care reports for the first time. Version 3 became required in January 2016, and the legacy version 2 database was decommissioned and unavailable for any new collection activity. As of today, all licensed services in Kentucky are submitting with regularity. We're still dealing with some timeliness issues on a month-to-month basis, but overall, the services are in compliance with the data collection regulation. It's important to note here that EMS data regulation specifically directs KBEMS to collect, maintain, and use data to assist ourselves as well as other state and federal agencies. So this partnership with NIOSH for occupational injury and surveillance is a prime example of why we're collecting data. The ultimate goal, of course, for EMS is positive health outcomes for the patients they encounter. But at the same time, we as an industry have to be cognizant of the risky situations that we sometimes find ourselves in. And that's part of NIOSH's role, is to make recommendations about best practices to limit exposures and injuries that are encountered by our workforce. We've talked about NIOSH, we've talked about the project and case stars. A little bit more about the National EMS Information System. So the current version of NIMSIS, which is version 3, contains a maximum of 585 different elements. Those unique incident response and patient encounter are contained in what's known as the EMS data set. Within this EMS data set, there are 27 groupings of like elements. Those elements of most interest to NIOSH are contained in the E other group. The history of NIMSIS goes back a number of years since the origins of EMS in the 1970s, and the need for information systems and databases has been well established and grown as technology advanced, both in a central location and all the way down to the caregiver in the back of the squad. NIMSIS was originally funded by the National Highway Traffic Safety Administration, or NHTSA, the Health Resources and Services Administration, or HRSA, and the Centers for Disease Control, or CDC, to support each state's efforts to collect, retain, and send data to a national database for research. Prior to the organization of NIMSIS, state and local EMS systems varied in their ability to collect patient systems and data. In 1994, NHTSA's Uniform Pre-Hospital EMS Dataset version 1 was born with 81 elements important to an EMS information system. Fast forward a few years to 2001, the National Association of State EMS Directors, NHTSA, HRSA, and other stakeholders worked to develop a national EMS database, NIMSIS as we know it now. This was formalized with a Memorandum of Understanding in 2003, with 52 states and territories signing on. 2005 brought about version 2.2, which included a standardized dictionary for the first time and formatting for information exchange. It was also in 2005 that a Technical Assistance Center contract was awarded to the University of Utah School of Medicine, and this arrangement remains intact today. A formal testing process for NIMSIS compliant software came in 2008. As of today, there are 39 compliant software packages and more in the testing process for compliance at the Technical Assistance Center. And these are at the agency or the collection level where care is administered. The latest version, that being version 3, was released in beta form in 2011 and finalized in 2013. So that makes it about 5 years old, and there are some changes on the horizon within the version 3 standard, moving from version 3.4 to version 3.5. Like Kentucky, NIMSIS no longer accepts this version 2 data, and we did contribute some of this for our year 1 activities related to this project, but there is no new version 2 data, and there are no services in Kentucky using version 2 now for several years. The online data dictionary for anyone interested in reading more about this is located at nimsis.org. So getting a little more into the details about the elements related to this project, within the E other group of elements are numbers 3, 4, 5, and 6. And these are key to this pilot program because they pertain to EMS practitioner injury and exposure within the confinement of that particular EMS response. That's not to say that an injury and exposure may require additional documentation per agency policy and procedure, including but not limited to a secondary EMS response for the affected provider and a corresponding EPCR for that response. The 4 elements involved are E other 03, personal protective equipment used, E other 04, EMS professional crew member ID, E other 05, suspected EMS work-related exposure, injury, or death, E other 06, type of work-related injury, death, or suspected exposure. NIMSIS elements fall into 4 categories: mandatory, required, recommended, and optional. We would expect to see mandatory elements on all incidents submitted to K-STARS because they are collected on each and every EPCR. Mandatory does not allow for a not value, with an example being not applicable. There are certain elements where not applicable is never an option. We would also expect to see required elements on all incidents submitted to K-STARS because they are collected on each and every EPCR. The difference between mandatory and required being the latter does allow for the use of not values. Not values are different than pertinent negatives. We would hope to see recommended elements, and we would hope to see optional elements. For the purpose of this study and overall data quality improvement, the Kentucky Board of EMS voted in April 2017 to make each of these elements required in Kentucky with immediate effect. And we'll talk more about that later. Digging a little deeper into the individual elements, E other 03, personal protective equipment used. The definition of this element is the personal protective equipment which was used by EMS personnel during this EMS patient contact. And the slide shows the options that are currently available as part of the NIMSIS version 3 standard for this element. E other 04, EMS professional crew member ID. This is the ID number of the EMS crew member associated with the other E other elements, 3, 5, and 6. In Kentucky, this would be a certification or license ID number. E other 05, suspected EMS work-related exposure, injury, or death. And this is simply an indication of an EMS work-related exposure, injury, or death associated with this EMS event. And we'll talk more about some of our findings on this particular element later. E other 06, the type of work-related injury, death, or suspected exposure. This is the type of EMS crew member, work-related injury, death, or suspected exposure related to the EMS response. There are a number of values that are selectable as part of the version 3 standard for this element, whereas some of them are more limited to a yes or no response. So we're in the second year of this project, and we wanted to do a year 1 recap. Kentucky submitted a business and technical proposal in the spring of 2017 in response to a NIOSH solicitation. Through the application process, we developed and awareness that not enough was being done in this area for the EMS community, and we're pleased to be one of 2 states selected that in all likelihood will lay the groundwork for future research in this industry. The project was awarded on May 12th of 2017 with work to begin in the first period of performance on June 16th and concluding roughly 2 weeks before the end of December. In year 1, we completed 3 extracts of data from K-STARS and submitted those to NIOSH successfully. We were also required to send in 2 education deliverables, one of which was a educational program very similar to this one, delivered in December of 2017. What we did in year 1 was actually the initial exports of data for NIOSH, and it revealed an embarrassingly low percentage of EPCRs collecting the 4 E other elements. And Monica will get a little bit more into those on the next year 1 recap slide. But I'd point out that one of the 4 was already required as part of the national standard, and 1 was recommended. In regards to timeliness, the board had recognized the importance of receiving data as quickly as possible for many research purposes, not only this project. We found after analyzing the average response time from unit notified to incident creation in K-STARS that over half of services were submitting EPCRs within 96 hours by leveraging technology already part of the NIMSA standard, where their system talks to our system without human intervention. Presented with that information, the board voted in April of 2017 to decrease the submission window from the 15th of the following month to 72 hours after completion of the incident. The board also voted to require the E other elements as part of Kentucky's required data elements. Each of these actions will require amendments to the EMS data regulation, a time-consuming process in itself. That being said, all services were strongly encouraged to begin voluntarily meeting the 72-hour and the E other required elements in anticipation of a regulatory change.
So over the next several slides, we'll be discussing the individual elements and actually what was submitted to K-STARS. The chart on the current slide shows the yearly percentage of incidents that submitted data for NIMS's elements E other 03, 04, 05, and 06. In a later slide, I will be adding the most recent 2018 data to this chart for comparison. Taking a closer look at the individual elements that was collected from January 1st of 2017 to December 7th of 2017. Only 14% of all incidents reported to K-STARS collected data pertaining to personal protective equipment used by EMS during patient contact. Of the incidents who did collect E other 03, 90% selected that gloves were used during the EMS event, and only 8% used both eye protection and gloves. The remainder of the data accounts for less than 2% of the runs that collected E other 03. The table on the left displays the top 10 most used personal protective equipment, and the corresponding pie graph on the right displays the top 5. Looking at E other 06, which is work-related injury, death, or suspected exposure, only 11% of all incidents reported to K-STARS between January 1st of 2017 and December 7th of 2017 submitted data for this element. As you might guess, there are some quality issues regarding this NIMS's element. We know that there is not 14 EMS personal line of duty deaths in 2017, and we'll discuss that a little bit more further on.
Monica, thank you for highlighting the recap of year 1. We were notified of an option 1 extension as part of this project in October of 2018, which allowed us to continue with the granular data sharing as well as future educational programming into 2018, which we're doing now by our team as well as the folks at NIOSH. As was mentioned earlier, the presentation is being recorded for publishing and distribution widely to Kentucky's EMS community. In year 2, we stepped up the awareness efforts of national and state required mandatory and required elements, including those of the E other group identified earlier in the presentation. Part of that awareness was the education program from December 2017. Some of it was outreach by doing poster presentations at different events and highlighting that with our different committees. And we'll get into that as well a little bit more. Our data committee member composition and other sharing partnerships that we've developed. We've talked about our successes, and we had hoped that they would have more of a snowballing effect on our motivation to continue doing better. We talk about doing this all the time clinically for continuous quality improvement, and there aren't any barriers to doing that for data either. It's just a matter of doing it. Some of our other challenges during this period in year two are specifically related to, and as Monica will highlight in an upcoming slide, the regulatory changes required to incorporate enforcement of required elements and timeliness. As was mentioned a few minutes ago, we have board approval, actually board action, to require these extra elements, but the data regulation says that we'll use the national standard. It doesn't say anything about how we will decide on adding elements to the state required data set. It doesn't tell us how we're going to implement that. Therefore, the most we could do was to provide this information to the other software industry partners who aren't using the image trend platform and request that they push those requirements down onto their services. Now, we did see an increase in timeliness, but as Monica will highlight, the data, well, it sort of speaks for itself. We can do better. So a little bit more about the rules and regulations. The data committee had requested a higher prioritization of data collection regulation updates. This has been on the committee's radar for several years, even prior to the board voting in April of 17 to increase the timeliness measure. As it is today, the data regulation has not been amended, and the proposed amendments are still not available because there are so many stakeholders interested in what that data regulation says. Changes to 202 KAR 7540 will require a full public comment period, and we hope to start that right after the first of the year. The primary conversation for change related to timeliness and defining the process for establishment of state required elements. We're finally at a point where the board has recognized how important the data regulation is. And just this past week at their final board meeting for 2018, they bumped it to their top priority out of all the pending regulatory changes needed. So we hope that this will take effect late spring, early summer. We were a lot more successful with our year two education activities. Dr. Gruenwald authored a very, very well put together abstract about this project. Monica then took some of the information from that and did some of her own to build a very visually appealing poster, which took second place at the National Association of State EMS Officials annual meeting in Rhode Island in May. And the poster was updated and took third place at the Image Trend Industry Conference in St. Paul, Minnesota this past July. The poster and the socialization of this has occurred at all of our EMS committee meetings that are slaved to the board. Talked about it at length with the board itself. You know, they're well aware of the project. We've discussed this project with external stakeholders, of course, our data committee at length. We've made presentations ad hoc at EMS conferences around the state. There is a better awareness now, which is one of several outcomes that we hoped to achieve throughout the year. What was holding us back in year two was the inability to enforce the timeliness and required elements Monica is about to highlight.
Thank you, Drew, and also feel free to chime in at any time over the next several slides regarding the data. The findings to date chart that you see on the current slide shows the yearly percentage of incidents using E-Other 03, 04, 05, and 06, dating back to 2015. This is the same chart from one of the previous slides with the inclusion of the 2018 percentages. When comparing 2015 to 2018, there has been a significant increase in EMS incidents that are collecting the highly important E-Other elements. However, KBEMS recognizes that there needs to be further improvement, and as I mentioned earlier, the board has voted to make these E-Other elements required within the new state data regulations. And as you can see, the number of incidents did take quite a bit of a spike from 2017 to 2018, because that we are happy to announce as of January of this year, all services are 100% compliant and submitting to KSTARS. Now, unfortunately, the E-Other 05 element for 2018 is not available at the moment, but it will be in the upcoming weeks.
So, as you said on this slide, so this is incidents year-to-date through last week, and we've seen already 105,000 and some change run volume increase, but we actually saw an across-the-board decrease in the utilization of these E-Other elements. Some of the decrease is attributed to the increased run volume. If we were tracking the same 725,000 incidents as last year, we would see an overall increase in the usage of these E-Other elements. So some of the decrease is actually attributed to the overall volume, and that's something that we'll be looking at in the coming weeks as we actually wrap up our 2018 data collection efforts in the middle of January, and we will be able to do an actual year-to-year comparison of these. As Monica mentioned, we ran into some irregularities with the E-Other 05 usage, so it's not available at this time during the presentation, but this will be updated to a slide deck made available on our website in the coming weeks.
On the face of it, it can feel a little discouraging to see these low numbers in the population of these variables that we're interested in. But it's important to remember that although it's a little bit slow, we really are making progress. And we do expect that the initiation of a new surveillance activity like this, that it's going to take a while for all of the elements to come together over time, and that's what we're working on now. So the data is spotty, but it's important to remember that we are making progress and we are learning things, because we are establishing an important element of the feasibility of using state-based NEMSIS data for occupational health surveillance, just by establishing that we can form these connections, and data can, for example, be transferred from the states where it resides to NIOSH databases where it can be aggregated, analyzed. We here at NIOSH are really not discouraged by this, and we're looking forward to another year of collaborating with KBEMS on this.
Now, taking a closer look at E-Other 03, personal protective equipment use data from January 1st of 2018 to December 13th last week, and we're comparing the data to see how it compares to 2017 incidents. As mentioned on the previous slide, only 13% of all incidents reported to KSTARS collected data pertaining to personal protective equipment used by EMS during patient contact. Of the incidents who did collect E-Other 03, 9 out of 10 selected that gloves were used during an EMS event. This data is not to say that EMS is not using personal protective equipment. However, agencies tend not to submit this data to the KSTARS database because E-Other 03 is not a national element, as we mentioned before, therefore not required to submit.
We know that crews are taking precautions to isolate themselves to bloodborne pathogen exposures. It's part of the core curriculum. The curriculum, nationally, it is ingrained into EMS providers to talk about body substance isolation before making patient contact. You know, it's ingrained to us. So we know what's happening. it's second nature to put on a pair of gloves as we climb out of a truck. Eye protection, it's all there. The equipment is required to be on an ambulance so that that vehicle can be called an ambulance in the first place. It's a simple documentation issue. So our education efforts that we need to focus on are just the completeness of an EPCR. These medical, these EPCR documents are medical records first, but they're an account of what happened on that call. So any of these records can be subpoenaed. De-identified records can be accessed en masse through Kentucky's broad open records law, whether it be for research purposes or other, maybe even nefarious reasons. One of the other aspects that's ingrained to us is if it didn't get written down, it didn't happen. So why are we not documenting the use of personal protective equipment in these charts? Is it a time thing? Do we want to get the chart wrapped up so we can move on to the next call, or maybe get back to the station and put the game on, or finish our lunch that had gotten interrupted? We'd like to hear this from the crews. Why are elements such as this one being overlooked? And it's not limited to these other elements. There are other elements throughout the PCR that are being overlooked that probably don't need to be overlooked, whether it be clinical, whether it be of a demographic nature, and so on. We know that completion of a full PCR is daunting. That said, we all have a collective responsibility to be as thorough as we can be, because this does become a history of what really happened.
Yeah, and if I could add to that, Drew, this is really where NIOSH is coming to the EMS providers in Kentucky and asking you for your help, because we know, as Drew and Monica have mentioned, we know that EMTs and paramedics wear gloves for the most part on every call. And as Monica alluded to earlier, we also know that there weren't 14 line of duty deaths in Kentucky in 2017. So we know that what we're looking at is not problems in the way EMS is practiced or provided in Kentucky. We know that what we're looking at are data errors. And that is what we're in the process of trying to improve, because we have to get this data quality to improve before we can produce reliable occupational health surveillance statistics. And it's those reliable statistics that we're going to hopefully use to make working in EMS safer for the EMTs and paramedics in Kentucky and for the rest of the country. So, and I think that perhaps one of the reasons why these particular other data elements sometimes get neglected is because it until recently hasn't been generally understood how important this information is. And this is what, as a representative of CDC and NIOSH, I am saying to the EMS community in Kentucky is, we want to use this data to make your job safer. And that's why we want you to know that we are interested in this data. And if we get high quality data, we want to use it to help make your job safer for you to do. So that is really sort of for NIOSH, the bottom line importance here is that we want you to know that this data is of interest to us because we want to use it to help you and help protect you.
Let's take a closer look at E-Other 06, work-related injury, death, or suspected exposure. Only 8% of all incidents reported to KSTARS any information pertaining to this element between January 1st of this year and last week. As mentioned previously, there are quality issues regarding these NIMSIS elements. Like Dr. Grunwald said, we know there's not 14 line of duty deaths last year, and there's not 11 this year. We're working towards improving data quality and completeness.
So one of the things that I've talked with these software developers about is putting an acknowledgement feature into their software, incorporating into the chart so that when critical questions are answered with an answer along the lines of death in E other 06. There needs to be a pop-up that says, do you know that answering this question in this manner is indicative of ... depending on what the element is that's being responded to in that way. Right now, there is no pop-up that occurs that says, hey, wait a minute, a crew member died during this. And if we were able to incorporate that functionality on this and a number of different questions, it would help with the overall data quality. Now, the good news is, for the most part, we've seen an overall decrease in the number of what we feel are glaring errors, but I happen to know of a dozen or more just here in the central Kentucky area where you get an ankle sprain or you get a back injury from lifting. That's not uncommon. The nature of the work that EMS professionals do on a daily basis, somebody's going to get hurt. And it doesn't necessarily have to be an injury or an exposure that involves time off from the job. So as we continue socializing what the goal of accomplishing is, making the job safer, we also need to explain that if something happens on the call where you're required to notify a supervisor of a needle stick or bodily fluid contact, those are the sort of triggers that should prompt, like I mentioned before, having a pop-up during a QA review to double check to make sure that these got added into the PCR, because finishing the patient documentation is probably the last thing on the crew's mind if a member of the crew has some sort of event occur on that call. There's a lot of ideas floating around how to improve data quality beyond just making these elements required in the software. And again, we'd be interested to know what the practitioner's view of this is as we go forward on this project and other projects. Wrapping this up as we approach an hour, for year 3, we've received informal notification that this project is going to continue into a 3rd year. Our office will continue to work closely with Dr. Groenwald for the quarterly data submissions, and we'll also be working to correct that irregularity that we discovered with the other 05. This recording will be posted to our website and sent out. We will do another one in December with a sort of a wrap-up of the activities as we've done today. We're going to continue to do data analysis throughout the year 3 period. Some of those findings get published in our annual report. We expect to see some information come from NIOSH during this period, so we can share that back with the practitioners. And I mentioned the regulatory change. The state required elements should be an enforceable item in the year 3 period, because it's been socialized that these will go into immediate effect instead of having a waiting period. Closing this out, as part of today's program, we want to let you know that we're willing to take questions at the email address on your screen. That's kstars@kctcs.edu, and either Monica or myself will answer those, or we'll pass them on to Dr. Groenwald as appropriate. But we do monitor that mailbox, and we appreciate everyone's, and several points throughout the conversation today. Hopefully that has spurred some questions, whether it be related to this project or data collection in general. And with that, I'd like to thank, on behalf of all the Board of EMS staffers who are not with us today, appreciate your attendance and watching this video. That's about all I have to add. Monica, Dr. Groenwald, if you have anything to close us out.
I'd just like to say thank you as well. Thank you, Monica. Thank you, Drew. And I'd also like to thank all of the members of the EMS community in Kentucky for the work that you do and for being willing to work with NIOSH on what we think is a really promising project. So thank you very much.